Thank you to everybody who has already logged on. We are going to get started in just a few more minutes. Thank you to so much everybody who's already logged on. We're going to wait just another minute to let a few more people get in and get their audio set up, and then we will begin the session. Thank you for joining us for this installment of the Root Cause Coalition's How To webinar series. My name is Rachel Carlson, and I am the Membership and Engagement Manager at the Root Cause Coalition. Before we get started with this presentation, I wanted to go over a few logistical items for the webinar. Attendees will be in listen-only mode for the duration of the presentation. This webinar is being recorded and will be available to view at rootcausecoalition.org/webinars later this week. At the end of the session, our panelists will be taking audience questions. So if you have a question during the presentation that you'd like to submit, please type your question into the question pane, usually located at the right side of your screen. We are so excited to have our esteemed panelists join us to share their expertise on making your health system truly person-centered. At this time, I would like to pass it off to Renee from Community Catalyst.
Good afternoon. Thank you so much, Rachel, and the rest of the staff at the Root Cause Coalition for the warm welcome. As Rachel mentioned, today's webinar is How to Make Your Health System Truly Person-Centered. This webinar is going to be focused on healthcare organization strategies for meaningfully engaging with individual patients or members, as the case may be, their families, and the broader communities they serve. I did want to take a moment just to acknowledge the urgency of where we are in this moment between the pandemic as well as actively confronting racial inequities. We're so honored and grateful that you chose to spend the time with us today. Next slide. So again, my name is Renee Marcus Hoden, and I'm the Deputy Director of the Center for Consumer Engagement in Health Innovation at Community Catalyst. I'm joined today by Joshua Traylor, a director at the Healthcare Transformation Task Force, and we're so pleased to also be joined by Dejo Miller, the Program Manager for Patient and Family Engagement at Children's Mercy Kansas City. Next slide, please. Okay, I just want to spend a minute going through the agenda for our time together today. So first, we were going to do this welcome, of course, and a few brief introductions to our organizations. We'll then spend some time talking about what we mean when we talk about consumer engagement at the organizational level and talk about a framework and some principles for that guided our work. The bulk of our time today will be spent on talking about a recent web-based tool called a change package. We'll be sharing key takeaways from 3 sections of that change package, one on planning, one on implementation, and the third on scaling. We'll then turn the microphone over to Dejo at Children's Mercy Kansas City to talk about their efforts on consumer engagement. And then finally, as Rachel mentioned, we will be taking some questions and answers from the audience. Next slide, please. So again, before we jump into the substance of the webinar, we'd like to provide some brief background on Community Catalyst and the task force. So I'll start with Community Catalyst. As some of you may know, we are a national nonprofit advocacy organization working to support the building of a strong movement of consumer voices that shape health and healthcare. It's our conviction that better health-related decisions are made when consumers and communities are at the table. And to that end, we work with state and local partners in about 40 states. As I mentioned before, I'm with our Center for Consumer Engagement and Health Innovation. And at the center, we focus on bringing that same consumer voice to efforts to transform the delivery system so it better serves the people who need it most: older adults, people with complex disabilities, people with multiple chronic conditions, and the like. And to do that work, we work really at the intersection of policy, advocacy, and practice in order to promote best practices, including on the topic for today's webinar, which is engagement at the organizational level. So I will now turn it over to Josh to introduce the task force. Josh?
Great, thank you very much, Renee. Next slide, please. As Renee mentioned, my name is Joshua Traylor. I'm with the Healthcare Transformation Task Force. The task force was established back in 2014, And we serve as a multi-sector industry consortium that brings together healthcare payers, providers, purchasers, and patient groups who are all committed to advancing transformation within the healthcare delivery system. Next slide, please. So this gives you a high-level overview of our membership. And our members aspire to have 75% of their respective business operating under value-based payment arrangements by the end of 2020. One of our big focus areas, in addition to the work that we're going to be presenting to you today, is thinking about the way that the healthcare payment system creates incentives for healthcare providers, for payers, and for patients, and really working to kind of reimagine how we can deliver care under value-based payment arrangements to improve quality, reduce costs, and create a better overall healthcare system, something that is more responsive to patient needs and more sustainable for the country. So again, very happy and excited to be able to present this work to everyone today, and I'd encourage you to check out our website for some of the other topics that we want to focus on. I will pass this back to Renee, who's going to give you a quick introduction to the framework that we'll be discussing today.
Terrific. Thanks so much, Josh. Next slide, please. So here we're going to get into the real substance of the presentation today. So let's start with the most basic issue. As I mentioned earlier, what do we mean when we say consumer engagement at the consumer level? So we're really talking about strategies for involving the people and communities who are most impacted by a healthcare organization. And again, this is whether it's a hospital, a health plan, a federally qualified health clinic, and so forth. And it's really about involving those people and communities in guiding organizational decisions about care or about community investments in order to drive progress on two major goals: improving health and stabilizing costs. Those are both related issues, of course. I do want to be clear, though, that this is not about involving people in their own care, which is an essential but different set of steps. So next slide, please. Okay. We first want to give you a sense of the framework that we use to guide the work that we'll be talking about today. Here you'll see a graphic description of 4 categories of engagement. In the center rings, you'll see 2 categories: communication and consultation. These are, generally speaking, one-way modes of involving consumers and communities, and they involve things like sending newsletters, appearing at health fairs, conducting surveys, or holding occasional focus groups. On the outer rings, you'll see 2 additional categories: collaboration and co-ownership. Now, generally speaking, activities in these categories reflect two-way engagement and include activities that you're probably familiar with, such as patient-family advisory councils at a hospital, or including members on a health plan governing board. So our work on this project was intended to highlight organizations that employed strategies from across the spectrum of these categories, and to also use the change package to spur organizations to kind of move along the continuum, if you will, to deeper levels of engagement. Next slide, please. Okay, so we also applied 4 basic principles of engagement to our work. The first is transparency and inclusivity. This includes involving historically excluded communities and striving for equity. It also includes taking concrete steps to make sure that everyone feels welcome and that they don't have barriers to participation. And we take steps to reduce those actual barriers that we encounter. The second principle is respect for different cultures. This means, for instance, approaching collaboration with humility and with patience. It also means that healthcare organizations have to recognize that communities are not monolithic, so they may have to repeat engagement strategies for multiple populations and for neighborhoods. The fourth, and of course related, principle is about investing resources. So I like to say that engagement isn't a side gig. It requires securing long-term commitment from institutional leadership and also dedicating real resources like skilled staff, funding, time, etc. The fourth principle that we applied is addressing power imbalances. This is about acknowledging a couple things. First, about acknowledging the power dynamics that exist between a health organization and community members, and that sometimes those dynamics have existed for decades. So thinking about the history as well. And it's also about acknowledging the existence of structural racism in our communities. And so from this acknowledgement, we can then start to move to actions like doing more listening and less directing. So I'm going to stop there and pass the baton back to Josh, who will start to provide some background on the change package itself. Josh?
Great, thank you very much. Next slide, please. All right, so I'm going to spend a little bit of time talking about, as Renee mentioned, background on the change package. If we could go to the next slide. So this was part of a two-part project that was supported by a grant from the Robert Wood Johnson Foundation. The first part of the project really involved a series of in-depth case studies with 3 different organizations that have invested in the type of organizational level engagement that we are covering here today. Those were Children's Mercy, Children's Hospital in Kansas City, HRH Care, a federally qualified health center in New York, and Trinity Health, a large health system that has over 90 hospitals across 22 different states. The second step was the development of a change package, which is what we're going to be focusing on today. The change package is intended to serve as a roadmap for healthcare organizations that are trying to develop sustainable consumer engagement strategies. It combines the lessons that we learned from our case study participants, as well as a review of the current engagement literature and resources that are available, and feedback from the project's advisory committee, who was pulled together to give us some oversight and provide their expertise. Next slide, please. So this is a screenshot of the landing page for the online change package resource. The individual sections are displayed in a blue box in the upper right corner, and this is intended to allow you to quickly navigate to the specific subsection that's of greatest interest to you. Over the next few slides, Renee and I are going to walk through the major takeaways from the planning, implementation, and scaling sections of this document before we turn things over to Deejo to talk a little bit about her perspective on the ground at Children's Mercy. Next slide. So I'm going to start off with the planning section here. And next slide, please. Thank you. This section is geared towards organizations with little experience in the type of in-depth consumer engagement strategies we're discussing today, although I will note that its contents are still a good refresher even for more seasoned organizations. And in here, we cover key considerations for leadership, work group development, strategy selection, and determining resource needs. Next slide. So in terms of the role of leadership was consistently identified as a key element to successful engagement strategies, really across everyone that we've spoken to as part of this project. Leaders in this context could be thought of as a CEO, but I think it's also important to note that this can be extended to management throughout an organization and even non-managerial roles. We stress that as a first step, the importance of leadership really in being open to an honest assessment of both the organization and their own personal approach to engagement. We've framed this as kind of, are you willing to walk the walk in addition to talking the talk? Another key theme that came up quite a bit is the importance of establishing engagement as the default setting for your organization. And a field note example that we include in the change package is from HRH Care, the federally qualified health center in New York. They are a Plaintree designated FQHC, and every new hire that they bring in participates in a 2-day retreat. It's focused entirely on patient-centered care. And they make it a point to highlight the patients that they care for in a patient panel that's called Quality from the Patient's Perspective. So I think that is a great example of kind of what we're talking about here, one of the ways of building this into a standard expectation for the operation of an organization. Next slide, please. So the building a work group section covers the building and planning of your work group. This is where we highlight strategies for recruiting a diverse group of consumers and staff to help guide with the planning effort. And we also stress the importance of practicing good engagement habits from the start. And so, what do I mean by good engagement habits? Well, examples of this include hosting meetings that are accessible to consumers in terms of both their timing and their location, and really investing in training and mentoring resources that help people to be active participants rather than just present in the room. And this was another thing that we've seen pretty consistently, that this is really entering into a relationship with the patients or the consumers that you're working with. And so it isn't just, inviting them to be at the table. It is an ongoing process of training and development and listening to them, and then also giving them the resources they need to be full participants. Next slide, please. So under the plan development section, we talk through the data collection and analytic tasks that a planning work group really should be engaged in. This includes reviewing the existing organization's performance on metrics and data that relate back to both quality of care and patient experience, and reviewing data on the community that the organization serves. In short, this is all about familiarizing yourself with the needs of both the organization and the people in the community that you're caring for. This is really the basis for the ongoing planning effort that we go through in the next steps here. Next slide. So, in terms of selecting strategies, we think of this as kind of rounding out the planning work. We highlight the role of interviews with both staff and consumers inside the organization. It's noteworthy that I think all the organizations we interviewed for our case studies discussed engaging with negative feedback specifically as being part of their learning experience. And this feedback really does inform the selection of potential engagement strategies, and ideally, we think these strategies should be weighted towards, as Renee mentioned, the collaboration and co-ownership approaches that were discussed earlier, those double-headed arrows that involve kind of a bi-directional flow of information. I think it's also important that we recognize that this may not be an easy thing for organizations to jump right into, but we think it should be built in as part of the kind of long-term planning for engagement strategies. Next slide, please. So kind of rounding out the planning section, we spent a little bit of time talking about resource requirements. And so this is where we review considerations for things like staffing and how staffing levels might vary by the type of engagement strategy selected. And as with the negative feedback being something that was sort of universally cited by the folks we interviewed as something to pay attention to, refreshments were also universally cited as a key to holding a successful meeting. Another important factor was really around how you support participation. And that really is key to, I think, building an environment that can support diversity of participants. And it involves budgeting for supports like transportation or parking vouchers, child or elder care, depending on the needs of the folks who are participating in your engagement activities, interpreters, and even considering things like honoraria and stipends. And then finally, recognition was cited over and over again as being a key to sustaining this type of work. And it doesn't need to be something particularly expensive. I think we've heard people note things like using certificates of appreciation or small awards for folks who really go above and beyond in special effort on a project. But taking the time to celebrate the work of the group and to recognize the contributions of people who are, showing up and giving their time and their energy to this is really, really critical. I'm going to hand things back off to Renee, and she'll go through the implementation section.
Thanks so much, Josh. Next slide, please. And we can skip that one as well. Next slide. Terrific, thank you. So the implementation section of the change package is really what I like to think of as the most kind of how-to section of it. And it really helps organizations turn their planning steps into reality. So this section is broken down into the following topics: building a multidisciplinary engagement team, recruiting and retaining advisors, acting on feedback, and monitoring the impact of engagement. This is also the section where we call specific attention to diversity and inclusion considerations. Next slide, please. Okay, so the first step on implementation is to build an interdisciplinary team that will guide engagement efforts at the healthcare organization. This can, of course, include those who were part of the planning team that Josh talked about earlier, but there are really two essential points I want to lift up. The first is that the team should be led by someone in the organization who has a clear connection to leadership. So as you'll see in the field note here, we talk about HRH care, in which case, where the leader of the patient engaged experience team, rather, is a person who also is a member of the executive cabinet. So, so she is a person who has connections kind of throughout the organization, but also has the ear of leadership across the organization. The second, equally important point I want to lift up is that the team should have the continued meaningful involvement of consumers and community members. And to make that real, we strongly recommend that they make up at least 25% of this multidisciplinary engagement team. Next slide, please. Okay, the sections on recruitment and retention of advisors are quite detailed. They address everything on recruiting, from suggestions around flyers to using health records to target particular populations you want to engage. But it places special emphasis on the importance of reaching out to community-based organizations, including and especially those that are led by and serve Black and Brown people. As for keeping advisors coming back, we highlight the importance of making sure that folks have a clear expectation about what they'll be doing, that they go through an onboarding process, and that they are provided with training opportunities, not just at the beginning of their term serving as an advisor, but throughout their term. And as a field note, we mention that at Children's Mercy, and DJ might address this later, that family advisors receive this exact sort of thing: training, written materials, and ongoing mentoring to support them in their roles. And they also work to match people to the best placement within the organization. And that will become clearer when Dijo talks about the variety of opportunities at Children's Mercy to engage individual advisors. Okay, so going back, probably the most important point in this section on retention is about making sure that you're giving your advisors meaningful and important work to do. And as I mentioned earlier, given the moment we're in, we really recommend using, or including rather, COVID-19 related projects, as well as those that seek to address existing racial and ethnic health disparities. Next slide, please. So while we're on that topic, the next section I want to draw your attention to is the one on diversity and inclusion. So first, let's talk about diversity. This requires dedicated attention to asking ourselves if our advisors are truly representative of the communities we serve, and thinking about that broadly. Do we have the right voices at the table? If the answer is no, who are we missing? And so this chart provides many of the demographic and non-demographic factors that organizations must consider as they're implementing their engagement strategies. So it requires the organization to do a deeper analysis of who's at the table and who's not there. Next slide, please. Second, I want to talk about considerations regarding inclusion. Again, this was, as I mentioned earlier, a guiding principle for the change package. And so in this section, we offer very concrete and replicable recommendations for leveling the playing field, so to speak, and for making sure that we're tackling those inherent power dynamics that I mentioned earlier, the ones that exist between healthcare organization staff and consumer advisors. So things like making sure that everyone uses the same approach for referring to one another. So for instance, instead of using in a meeting Dr. Smith to refer to the physician in the room and Bessie for the consumer, use first names, use Joanne and Bessie, so that everyone's on the same level. And this slide includes a few additional very concrete tips for making a much more inclusive environment. Next slide, please. So next, the section on acting on feedback helps organizations to close the feedback loop, so to speak, which is a really essential step both for retaining advisors, but also for being a learning organization. So this involves things like making it clear to advisors what happened to their feedback. And that's the case whether their feedback was taken or whether it wasn't taken. And also just having the humility and the flexibility to make course corrections when something does not go well. Next slide, please. The last section that I want to talk about is about monitoring impact. And I note that this could be a webinar, of course, unto itself, but it is critical that health organizations measure the impact of their consumer engagement strategies. It's not just a nice thing to do, it's the right thing to do, and it also can have a measurable impact on the goals of achieving improved health and stabilizing costs. So this section mentions ways to measure the impact that involve selecting both process and outcome measures, as well as using both qualitative and quantitative strategies. Importantly, to get at health equity issues, we recommend that health organizations specifically measure for diversity, equity, and inclusion. And finally, from the standpoint of demonstrating the value of engagement, we recommend that organizations communicate the impact of the engagement both internally so that folks within the health organization understand why we're doing this work, and externally to demonstrate that the organization is committed to this work and that it matters. So I'll pass the baton one more time back over to Josh, who will talk about the scaling section.
Great, thank you very much, Renee. Next slide. And maybe we can skip that one. Wow, thank you. So the scaling section is really geared towards organizations that have already established an engagement strategy and are really looking to spread that strategy to other service lines, clinics, or departments within their organization. We've broken this section down into culture change, policies, tools and resources, and finally strategy adoption. Next slide. In the area of fostering culture change, we really build on what we've covered in the leadership area that we led off the planning section with. Engagement should be incorporated as a default in the mission statements, budgets, job descriptions, and other routine activities of the organization. And it's also important to highlight the value of supporting the development of collaborative relationships with consumers and incorporating them actively into day-to-day meetings that the organization might be having. So really, I think this is all about making the concept of engagement much more the default as opposed to a separate add-on thing that you do when you have time. Next slide, please. The section on engagement policies, I want to highlight the importance of balancing uniformity and flexibility. This was a key finding in our discussion with Trinity Health. As I mentioned, they're a multi-state healthcare system with over 90 hospitals. And so they, in discussions with us, talked about how they worked on setting broad goals for engagement, and worked on providing supportive resources like a patient and family advisory committee toolkit that one of their hospitals had done quite a bit of work to kind of build out and develop. So they took that as a best practice and used that as an opportunity for knowledge sharing, but also highlighted the fact that they needed to be able to leave some flexibility for a system that has providers working in Idaho as well as in Michigan, and the fact that there needs to be separate solutions given the variation in local context. So we think that while not everyone has a multi-state healthcare system to deal with, this is still a very important consideration, even if you're trying to spread something across two different service lines or two different departments within an organization that's all located on one campus. Next slide, please. So as I mentioned on the previous slide with the PFAC toolkit, identifying opportunities to create standard tools and resources is very helpful for scaling engagement strategies. Being able to provide a resource or a toolkit up front helps to kind of lower the barrier, reduces the activation energy for implementation. It makes it easier for folks to kind of get their heads around what you're asking them to do and to really get started, because they know that some of the work that they might have to normally spend time planning and doing themselves has already been done for them. That doesn't mean that they'll necessarily be able to take a standard tool or resource and run with it completely. It may still require some customization for their specific situation, but it does really help people to, I think, kick things off and kind of get the ball moving. Next slide. Our final section here on scaling is all about strategy adoption. And so this section focuses on further lowering the barriers to getting started. Approaches that might be helpful include inviting leadership and staff who are new to an engagement effort, who you might be asking to start this work, to attend established meetings in other parts of the organization, highlighting concrete examples of positive results, and creating opportunities for ongoing shared learning. This is another thing that we heard pretty regularly, both routine shared learning opportunities and highlighting concrete examples like one that we heard that was particularly salient was the design of new patient areas, patient spaces that have been done without engaging patients initially. And when they brought patients in to review the space, they highlighted all of these areas that in hindsight were very common sense and were easy to fix on paper in a blueprint. But had they gone through the complete build out and then gone back and had to make those adjustments, it would have been much more difficult to do. So again, examples of concrete positive results from engagement activities. So next slide, please. So I now have the pleasure of passing things over to DJ Miller, who's going to talk a little bit about consumer engagement work at Children's Mercy Kansas City. DJ.
Great, thank you. I think you can go to the next slide. And I am DJ Miller. I am one of the parents on staff at Children's Mercy. My daughter was diagnosed and successfully treated for cancer when she was 13 and 14 years old. And I've been working in the patient and family engagement department for about 12 years now. And so I'm honored to be here today to highlight some of the ways that we engage patients and families in everything that we do. Next slide. So I'm going to level set just a little and give you a little bit of information about Children's Mercy before I talk about our engagement. Children's Mercy is the only freestanding pediatric hospital between St. Louis and Denver. We have 366 inpatient beds between our hospital in urban Kansas City, Missouri, and roughly 40 beds in our suburban hospital located in Overland Park, Kansas. And in all aspects of our hospitals and clinics, Children's Mercy is very intentional in engaging patients and families in everything that we do. So I'm going to share some of the examples of how we've ingrained person and family-centered care into our culture. You can go to the next slide. This is a graph that shows the growth of engaging patients and families at Children's Mercy through the years. And I'm going to use the term PFA, or Patient Family Advisor, to describe the volunteers who are engaged to share their perspectives of what it's like to be on the receiving end of care. So in our case, these volunteers are either teenage patients or their parents and guardians. And the number of engagements refers to the spots on committees, councils, educational opportunities, and not the actual attendance of the PFA throughout the year. So the first data point is from 1998, when 3 parents were invited to attend a hospital environment meeting. In 1999, the first Patient and Family Advisory Council was started, and it was the Teen Advisory Board. Then in 2003, our Chief Operating Officer started the Family Advisory Board, which was created to encompass the perspectives of the parents and guardians of those patients. In 2008, Children's Mercy hired 2 parents to serve in the role of parents on staff to ensure that the perspectives of the end users of healthcare were available all of the time, beyond the meetings of the advisory boards that were already in place. Myself and another parent were hired. And initially, there wasn't a strong job description of what we would do, but rather we were given the opportunity to collaboratively work with staff and grow our roles over time. Having us on staff to build relationships and manage the onboarding of volunteer advisors was where we saw the first real increase in engagement. The next jump up in engagement came in 2012 when we implemented a patient and family-centered care policy, which has evolved into a patient and family engagement policy to encompass our advisors and PFACs, our Patient Family Advisory Councils. So this policy guides and directs us as an institution. The policy's purpose is to foster an environment of collaboration within the hospital where patients, parents, and primary caregivers are active partners with the organization, resulting in better health outcomes, improved patient and family experience of care, better clinician and staff satisfaction, and wiser allocation of resources. This policy not only directs staff that engaging patients and families in the design of care is okay, but that it's expected. The policy lays out how to do this so there's consistency across the organization. And our department facilitates this work and supports the staff and PFAs. After the policy was in place, we classified the culture change in 2015. The rate of engagement continued to increase, but the requests for advisors to be embedded in all aspects of work started coming from the organization, as opposed to years earlier where we, as parents on staff, sought out those opportunities. Finally, in fiscal year 2019, we had 850 instances of PFAs working alongside staff on advisory councils, education, projects, and committees such as all of our hospital-acquired conditions teams, health literacy, ethics, quality and safety council, and many, many more. We found that having a team and policy in place has been instrumental in this culture shift to person and family-centered care. Next slide, please. This shows the hospital's commitment to engaging patients and families is also evidenced in the number of parents we have on staff and the growth of the patient and family engagement team. The 7 parents on staff represent 4.5 full-time positions, so some of our parents do work part-time. Next slide. This is our wheel of PFACs. Children's Mercy now has 17 patient and family advisory councils with a mental health PFAC that started this spring, and it's not listed on this slide. In addition to the 3 system-wide boards at the top, the Family Advisory Board, the Teen Advisory Board, and the Latino Advisory Board, El Consejo de Familias Latinas Hispanas, Children's Mercy has 14 department or topic-specific PFACs. So each PFAC has a unique structure to meet the different needs. Some are population-based, such as the NICU, or research-focused, like the rare PFAC, and others were started to work to support work in national collaboratives, and also those that are location-specific, such as the Kansas PFAC. Our team, Patient Family Engagement, provides the guidance and support to the staff facilitators and the volunteer members of these PFACs. Next slide, please. One of these PFACs is El Consejo de Familias Latinas Hispanias, which we call Consejo, and was started in 2008. Children's Mercy recognized the value of creating a council separate from the existing Family Advisory Board in order to meet the language and cultural needs of a portion of the patient population. A well-respected bilingual physician spearheaded the development of this council, meeting informally with interested families, sharing meals, and meeting in a safe and trusted space. It became evident that this council would be better served as a separate advisory group from the Family Advisory Board, to have its own norms and processes to allow a more culturally sensitive interaction with members and the hospital's leadership. The members continuously express their gratitude of having a doctor work alongside them that also provides care in their language as well as understands their culture. One parent was quoted as saying, "I feel safer because I can talk to the doctor in my language, and that helps me to better describe what is going on with my child. He also understands my culture, so I trust him." All of the Consejo meetings are conducted in Spanish with an interpreter present for the staff members who are not bilingual. Consejo has raised the awareness for staff about not only language barriers, but also cultural differences and the impact these differences have on healthcare. Next slide, please. And because they have the longitudinal experience of working with us for over 12 years, Consejo members have gained knowledge and trust that their input helps make care better for Spanish-speaking patients and families. And they're now comfortable speaking up in this environment. When new members start, they are reassured by the veteran members that the hospital listens to them and what they say makes a difference, because we have continuously provided feedback on what we do with the information that they share with us. Next slide, please. Here are a few examples of their accomplishments. The Council often provides consultation for hospital initiatives, such as information shared on the patient portal and the website. Members often review brochures and educational materials for families to see if the translation makes sense to them, or if there needs to be additional information to address cultural differences. It's often not just translating the words, but also the meanings. The Spanish language radio spots is an example of members wanted to share the medical information they were learning with a Hispanic community in Kansas City. They helped develop the topics and ensured that we continued with the project even when barriers popped up for us internally. And several communication tools were developed as a result of the needs identified by members, such as metal rings with pictures of commonly requested items, so all languages can communicate their basic needs. Next slide, please. This timeline shows the stages of how we got to where we are today. This intentional focus on engaging patients and families in every part of the process was started and has been sustained because of the hospital leadership's commitment to a patient and family-driven culture. Our case study documents a more comprehensive outline of the strategies we applied to engage patients and families into everything we do from the bedside to the boardroom. Next slide, please. I'm going to share some examples of how we have engaged patients and families in our response to COVID-19. And this strong foundation of patient and family engagement has continued without missing a step since the onset of the COVID pandemic and the sudden and drastic changes that occurred in healthcare. An early example of engagement occurred when we were first instituting visitor restrictions. A small task force was convened to discuss the restrictions and to draft a policy within a few days to get approval from the COVID-19 task force. And the team consisted of an infectious disease doctor, the senior directors of inpatient nursing, ambulatory nursing, perioperative nursing, and me as a parent on staff. It's just in our culture to make sure that the perspectives of patients and families are represented, and having parents on staff allows the hospital to easily leverage our engagement. In regard to our PFACs, all our on-site meetings were canceled starting on March 16th. And since Children's Mercy uses Microsoft Teams for our virtual platform, we created a PFAC virtual meeting toolkit to support volunteers and staff to effectively transition to this new platform. So by April, all of our PFACs were meeting online. In order to transition our Spanish-speaking PFAC, we met virtually with a couple of the Consejo parent leaders to collaboratively make a plan for moving their members to a virtual platform since they had not traditionally communicated via email, and they needed a little bit of a different strategy. At the same time, our team, Patient Family Engagement, provides regular emails to all of the PFAC members about Children's Mercy to keep them updated on the changes during this time so that all of our PFAC members are ready to provide feedback. And there's ongoing collaboration with parents for the COVID-19 updates. And in times of fast turnaround, we may only consult with 2 or 3 PFAs, but with regular PFAC meetings and updates, we have over 200 PFAs to reach out to for feedback. We've also continuously engaged advisors on our equity and diversity work groups and steering committees. And recently, the mental health PFAC provided suggestions for information they would like to see on our public website to help families talk about what their children are seeing on the news. After conducting a PFAC demographic satisfaction survey last fall, we also created a PFAC work group that collaborates with staff to ensure that our PFAC recruitment strategies ensure our members represent the patient populations we serve. Next slide, please. This is an example of our public website and information that is shared. We always want to highlight that parents and guardians are not considered visitors, even during these changing times. You can go to the next slide. This slide shows how we address families to explain the new restrictions being put into place. First, we explained why. We said, with the outbreak of COVID-19, Children's Mercy is taking steps to protect our patients and their families, staff, visitors, and community. We are strictly limiting visitors to Children's Mercy until the spread of COVID-19 is no longer a threat. Our team works alongside communications and marketing. We are there and the best outcome for the patients. Next slide, please. Information that was posted on the website as a result of what the parents shared with us during PFAC meetings. Parents wanted useful information to help them navigate these changes with their families, in addition to the medical information being shared. So utilizing our trusted specialists, we continue to provide information on our website. You can go to the next slide, please. This is an example of our visitor guidelines. They are color-coded for ease of reading, and they reiterate that parents and guardians are not visitors and may be with their children at all locations. And also it shares that that restricting visitors was a difficult decision, but safety for all is the reason that these steps have been taken. You can go to the next slide. This is one more example of the impact of having someone who is on the receiving end of care collaborate with staff on messaging, even with short turnarounds. So the initial message that was created by communications read, based on CDC and national guidelines, we are canceling elective surgeries. We will call you to reschedule once we have a better understanding of implications and restrictions are lifted. And as parents reading that, it didn't feel good. And so we rewrote the message to still get the same information across, but in a way that families could hear. So the new message reads, COVID-19 coronavirus will stress our healthcare system, and we must conserve supplies, hospital beds, and healthcare providers to care for those affected. So we told families why there were changes. Based on CDC and national guidelines, we need to cancel surgeries that are elective and are not emergency. So we told them what was happening now. We will call you to reschedule your child's surgery as soon as it is safe. We told them what to expect. And thank you for helping us care for our community. We acknowledge their role in the bigger picture of a global pandemic. And you can go ahead to the next slide. These are just two examples of PFAC meetings before and after our on-site restrictions were enacted. So while we all love to be in person, we also value and know the importance of engaging with our consumers continuously, especially during these quickly changing times. So thank you so much for your time today, and I'm looking forward to answering some questions.
Thank you so much, Dejo. Really appreciate understanding more about the journey at Children's Mercy, but also, really clear examples of how Spanish-speaking patients and families really are driving decisions at the organization. So I'm going to pass the baton over to Rachel to moderate questions and answers.
Yes, so if you have any questions that you would like to ask any of our presenters, you can type them in the question pane and we'll read them out. We have time for a couple of questions. So the first question, specifically for Community Catalyst, what indicators are you using to measure equity?
Yes. So measuring equity involves looking at, I think, a variety of things. One, of course, is about the demographics of your advisors, as we spoke about earlier. And again, those are demographics that are specific to race, ethnicity, et cetera. And also, I think it's important to look at the types of topics that were taken on. Do those have an impact on equity and achieving health equity, and what were the impacts of that engagement? And then I think it's important to also measure inclusivity. So a lot of the things I spoke about earlier with respect to the steps that an organization can take to make it more approachable, whether that is, the way that the room is set up, the way that people are prepped for meetings, and the ability to, for those advisors to feel engaged and included. And so that speaks to also doing some surveying of your advisors to understand what their experience has been.
Great, thank you so much. Another one of our participants asks, what advice do you have for organizations that are beginning to invest more deeply in consumer engagement strategies?
Josh or Dejo, do you want to take that one?
Dejo, I defer to you to have first comments since you've lived this on the ground, and then I'm happy to contribute thoughts as well if need be. Dejo, you might be on mute. All right, we may have lost Dejo. So yeah, I guess I would say based on what we've seen and what we have reviewed in terms of talking to other organizations, I think there was a lot of emphasis placed on being very thoughtful in where you are placing investments and in terms of investing in both um, staffing on site who can help you with training and essentially onboarding people. So I'll use an example from some of our conversations with Trinity. They've done quite a bit of work in developing resources that could be scaled to other organizations, but one thing that couldn't be kind of packaged up in a resource and then scaled is the sort of staffing on the ground. And they had one individual in particular who had been working at one of their hospitals for a number of years, and she would essentially onboard new people who were interested in participating and conduct kind of an initial interview with them to figure out much more about what exactly it was that they were interested in doing, how they wanted to engage with the different strategies that the health system had available. And really, I think it was framed almost as one of the patients described it as almost like having a coach who sort of helps to place you in the best position for you to succeed, for you to be able to contribute in the way that you want to, that aligns well with the time that you have available, and who also would spend time ensuring that people understood the health system, how the meetings operated, and that they weren't just sort of told, okay, great, you want to participate, show up on this date at this time, and sort of figure it out as you go. So I think that that staffing perspective came up again and again and again as being key. That specifically you need people who have a great deal of empathy and who are interested in kind of coaching and doing that work to help develop people to participate.
And Deidre, I think her audio just came back. So if you want to answer that question as well, I'm happy to read it again if you need. It was, how can organizations integrate consumer engagement strategies during the pandemic? Oh, sorry, that's not the right question. What advice do you have for organizations that are beginning to invest more deeply in consumer engagement strategies?
Okay, so I really think that it's twofold. It's having someone that on staff whose focus is that engagement, because staff need the support, as do the volunteers and consumers, and having someone who has dedicated time to work on that was really helpful. And secondly, having the leadership support. So when we had leaders who in their messaging said, is there a PFA on this committee, and kind of putting that into some of the charters for a lot of our work groups, and improvement work has increased that. But that came after we started that implementation process, and it's really building trust and having somebody that helps the support helps support the staff. The staff are incredibly busy, and to be able to be that mediary that says, finds out, or suggests having an advisor on their committee or work group, and being able to work with them on, like Josh and Renee talked about, the timing of those meetings and when those occur, and so that we can help those parents or advisors, patients participate. And we help coach. We go in with them to their first few meetings to help with those introductions. And it's really a small investment for the return that you get, and that engagement throughout your organization. There's learning that occurs for every member of that team sitting around the table when a patient family advisor is present. And I think if you look around and say, is the person that has the highest stakes in the game here, that's the consumer, the patient and family members, that you need to do that small investment and make sure that you have the strategies in place to help support the staff and the volunteers.
Great, thank you so much. And thank you to all of our presenters. This was really excellent to learn about how we can specifically move forward in doing this, and I really appreciate your concrete examples and thoughts moving forward. And thank you to all our participants for joining and for asking questions. We are a little bit over our time, so I want to be mindful of people's schedules and let you get back to your day. But thank you so much for joining us. As a reminder, the session has been recorded. It will be available on our website at rootcausecoalition.org/webinars later this week. If you would like to present on a webinar sometime, you can contact me, Rachel Carlson, at rcarlson, that's RCARLSON, at rootcausecoalition.org. Thank you so much. Again, thank you to presenters, thank you to everyone who attended, and I hope you have a great rest of your day.